think about the aesthetic zone, when you're dealing with problems in the aesthetic zone, everything is critical, everything is important because everything is visible. Anything that you do, the slightest mistake, the slightest problem and complication is going to show and may cause your treatment to fail. So when you're thinking about replacing a tooth in the aesthetic zone, let's say a central incisor, the three most important things doctors are concerned with, number one is the interproximal tissue or the papillae, having some symmetry with the adjacent tooth, and having good tissue contour, and that basically improves the emergence profile of your implant restoration. If you have all three, you're doing pretty good. Now, a lot of the doctors are very concerned with all three of them, and in this presentation, I'm going to show you a couple of techniques how you can come on top. Now, unfortunately, we are working and operating against all the odds. There's a natural pattern of resorption of ridges. Once the tooth is extracted, in spite of grafting, in spite of immediate placement, immediate provisionals, in spite of soft tissue grafting, your ridges are resorbing. There's almost no way to stop it. I'm going to make some suggestions during the webinar on how I see this improving in the future, but we are working against the odd. We're working against a natural resorption of the ridge. And of course, when disaster strikes, when you have some type of big infection, a fracture under the bone, a root perforation, a bad resorption, and you need to work really hard to extract the tooth, these problems actually become much more severe and much more difficult to handle. The extent of the defect, what's next? Okay, and I think this is the time to dispel a myth. A lot of us are very concerned grafting infected sites, and I was always of the opinion that you need to graft infected sites. Okay, so a myth is don't graft infected sites because your graft material will get infected. Actually, my opinion is this is the best time to graft. You have a patient who is anesthetized, you expose the full extent of the defect, you cleaned it out, and even more important, the source of the infection is out, no more infection in the socket, and the tissue is ready to heal. The tissue is many times distended and swollen, so you have some extra tissue to cover the graft material. There's really no downside. Think about it. If you are grafting and your grafting was not successful, anyhow, you have to go back and graft again. So really, the best time to graft is at the time of the extraction. And that is not to say that it's always 100% and we don't need to go back and graft more, but the timing is right at the time of the extraction. So let's go. A patient's dentist asked me to preserve the crown and send it back because he would like to bond it as a temporary. So what I did, I actually sent back the crown, but I cut off a little part of the root. And the reason I'm doing that, what I'm doing here, I'm processing this root fragment, this dentin and cementum, putting it into a dentin grinder. Okay, it's a specialized grinder for teeth. Okay, it's called a Smart Dentin Grinder by a company called Cometa Bio from Israel. And I'm pulverizing the root and creating a particulate graft that is now called a dentin graft. Now, what's in there? The majority of this material is dentin because the majority of the tooth structure is dentin, but we obviously have a little bit of cementum. If we didn't need the crown, I would have pulverized the whole tooth. I would have had some enamel as well, which is basically hydroxyapatite, and that's all good stuff. It's pulverized into small particles of the ideal size for a bone graft. It's not a bone graft, it's a tooth graft, but don't forget we also have some organic tissue in there. And for that purpose, we need to use a dentin cleanser to clean out all the organic material. It's a process that takes about 10 minutes. And then we use a buffering solution to buffer the pH. In order to enhance this graft, I'm going to add some PRF. I'm going to add some metronidazole, basically adding some metronidazole from a capsule. I'm going to add the particulate graft. I'm going to add PRF. I'm going to add some metronidazole, mix it all up, condense it into the socket, compartment grafting using a PRF plug right on top, 2 little X-sutures, and basically you're done. So really, doctors, look at this. Something that should have been very complex in terms of the extraction process, in terms of handling the site, is facilitated with the Benex system. And I wanted to mention the advantages of dentin grafting. In case you're asking, the doctor from India is asking, is this really osteoinductive or conductive? It's definitely any bone graft is osteoconductive, meaning allowing the bone-forming cells to migrate upon and create a good scaffold. But in reality, if you think about it, dentin has growth factors and a lot of other things that participate in the healing process. But just if you think about the concept of grafting a tooth back into its socket, if you think about a tooth that came out and you're placing it back, the reason these things work is because the tooth gets ankylosed. So guess what happens? Each particle gets ankylosed with direct bone apposition on the graft. If you think about a dentin and bone, the alveolar bone, have been together all the time, and it's a perfect marriage between tooth structure, now in a different form, and bone. And if you think about each and every particle, let's say a few hundred particles, all being ankylosed into the socket, you're getting the most stable bone graft and the better quality. And in my experience now, using it now for a few months, I'm getting great implant sites with very good stability. Now, you can also use it for immediate placement. That's my bone graft of choice, and I explained why. And this is a case of an immediate placement of replacing a resorbed tooth, central incisor. Okay, and again, I didn't need to use the Benex here. The tooth was completely intact. You can see the resorption. Once the tooth gets pulverized, there's a very simple principle that you're getting double the volume. So you're getting a lot of bone graft material. So if you think about it, if you're doing larger cases and if the patient has some third molars that need to be extracted anyhow, you can get a lot of bone graft material, not to mention that it's not going to cost you anything except for the processing, okay, which is very, very minute. And you're getting a very stable and good bone graft. So in this case, because it's an immediate implant, I'm grafting the gap between the implant and the buccal plate with my dentin graft. And in my experience, after using it for a few good months and many, many cases, it doesn't only look good radiographically and on a CT scan, very, very dense. I'm looking at beautiful soft tissue preservation and preservation of bone and a very good implant site going back in there sooner than later. And actually, I don't recommend you wait too long, because this extraction site and the bone is going to become very, very dense, actually too dense to your liking. So I would say 4 to 6 weeks later, once the soft tissue is healed, you're ready to go in there with your implant, unless you're doing an immediate, okay?